Bismillah ar-Rahman ar-Rahim. About short reporting exam, the Frcr 2B, we have 25 cases of in the exam. It is divided into 75% adult cases and 25% pediatric cases. Okay, the cases will be divided according to the systems. Short reporting only one modality, plain radiograph only. So we have chest X-ray will take about 50 to 60% of the exam, and musculoskeletal cases will take about 40 to 50% of the exam, and maybe one abdominal radiograph will come in the exam, which represent 4%. So the most important thing in this exam is chest radiograph. So you have to practice more chest radiograph. Second, the most important MSK, and you have to practice adult and pediatric cases also. Tips for short case reporting. We have 120 minutes duration for 25 cases. So every case will take 5 marks. The new exam modality will, they told no half marks in the case. So all cases are abnormal. Before the cases there were normal cases. Now all cases are abnormal. Written only, no oral like viva. Your report should be short report. You have to be concise. Simple statements of your observation. No more description. You have to describe, but little description. Okay. You have to write the diagnosis. Every case has unique diagnosis. You have to put the correct diagnosis for every case and recommendation for management steps. You don't need to write full sentences. Not like long cases. You have to write more description, more like this. No, a short sentence and on targets will be correct. The scoring system, you should know how they score the exam. If you will take 4 to 5, so you will detect all major finding and most minor observation. You will make correct diagnosis or differential diagnosis using clinical information proof. I think they intended to do one correct diagnosis. So if you reach the diagnosis, you will take high marks. For differential, you will take marks, but not like the one who made the correct diagnosis from the start. Also, you have to take high marks. You have to make safe further management with clear recommendation. You don't have only to refer the patient to chest MDT or orthopedic MDT. No. If you want to take high marks, you have to tell what they will do. Okay. Demonstrate clear understanding of likely further management required by different MDT. Your report should be clear, logic, and concise. Also, you may demonstrate knowledge beyond the core curriculum. So if you told one new management steps, one thing not included in the curriculum, you will may take 5 marks in the short case. Second one, you will take 3 if you detect most major findings, include those marked essential and some minor observation. May or may not reach the correct diagnosis, but demonstrate sensible clinical reasoning. As you put the correct differential diagnosis, and also may not follow management, but demonstrate enough knowledge to not compromise the patient safety. You should be safe. Whatever they will do, you should be safe. So if you detect the major finding, but not all, but you may or may not reach the correct diagnosis, but you are safe, you give safe differential, you will take about 3 marks. And also your report is clear. Also, it may be not ideally structured like 4 to 5. Okay, the last one, zero score. Zero score, no answer provided, you will let the case empty, or inappropriate, unsafe patient management. If you told the major finding everything good, but in your management steps you affected the patient safety, you will take 0 marks. By the way, this in all parts, viva, long cases and short cases also. How to train yourself? Now you have 2 months to train yourself on short cases, long cases, and viva. About short cases, you have every image you have to describe, localize abnormality, uh, both pertinent negative for every case, both differential diagnosis or differential diagnosis, and most important thing, you have to know the safe management for every case. Your short report structure. You're finding little concise description. You have to put common signs like hilum Verlet sign, silhouette sign, Caffeine sign, cervicothoracic sign. Pertinent negative, like symmetrical breast shadow. If there is a case of metastasis and you are suspecting metastasis, you have to mention that you look at the breast shadow and symmetrical, no surgical clips. You have to comment on the other lung. Also, you have in every case of the chest, you have to comment on the pneumothorax, pleural effusion. Your diagnosis, you have to write diagnosis for every case. Train yourself to write this imaging finding are consistent with like this. Differential if there is. If the case has differential, you can write differential, but not on the all cases. Your management, you have to refer urgent case or not, referral to which team, what further imaging you can do, and what team will do. Don't do these mistakes. Jump to diagnosis. Don't go for diagnosis. You should describe. Little describe, but you should describe. Long phrases. You should be concise. Missing safety point. Don't miss safety points. If you didn't find any abnormality, you have to go by checklist. In chest, you have to search for any rib fracture, for any new mediastinum, for any lobar collapse, for any pneumothorax, for any pleural effusion. Like safety points like pneumothorax, pneumoperitoneum, very important. Any fracture is safety point. Don't go for rare diagnosis. Please, common is common. Common pathologies of uncommon presentations is FRCR to be examined. Don't do unsafe management. Please, for your management, be safe. Don't ask for biopsy for non-biopsy lesion. If the patient is urgent, you have to refer urgent referral. So be safe, please. Recommended sources for short exam. We have this box is chest X-ray. It is related to normal and some abnormality. It is very good in the description how to go through the chest radiograph. It is very concise and it is very good book. Second one, accident and emergency radiology. This book was beneficial for normal, but also you need this book. If you have time, you should revise this book because it is very important about variance because you may see something, you consider it a fracture, but it is normal variant and the fracture in another side. So it is very important to revise both of these books. Third one, this for pediatric radiology, it was for rapid reporting, but you have to look for the abnormal cases. It is very, very good source to revise the abnormality in pediatric patients. How to prepare yourself? Practice, practice, practice. Practice will make you perfect. So don't waste your time. You have to practice more and more. And you have to put body structure of the report. in every case. In the exam, no time to think. You don't have time. You should know if this case like this, I will write 1, 2, 3. If this case like this, I will write 1, 2, 3. So you have to practice by reporting, not by your eyes only. We will start by the first case. So we have candidate one. Can you unmute yourself?
Yes, sir.
Good evening. How are you?
Uh, Good evening, sir. I'm fine.
Okay. Your first case, this 81 years old male patient referred from the GP with cough and weight loss. You have to describe as a short report, okay? Not like viva.
Okay, okay, sir. I'm presented with a chest radiograph frontal projection of a skeletally mature patient. On my first look, I can see there is some volume loss in the left hemithorax, and I can appreciate there's a retrocardiac opacity with some obscuration of the left hemidiaphragm. I can I can appreciate right hemithorax appears unremarkable. Trachea seems to be central. There is no evidence of pleural effusion. There is no evidence of any pneumothorax. I'm looking at the bony thorax and the soft tissues, which seems to be fine. So on the basis of this chest radiograph findings, I am suspecting left lower lobe collapse, which can be either secondary to endobronchial tumor due to mucus plugging, or maybe due to chronic foreign body aspiration. So I will further advise contrast and CT chest, and they will further advise the bronchoscopic evaluation, and I will refer the patient, then refer the patient to the pulmonology MDT accordingly.
Urgent or not?
Uh, yes, urgent. Needs
Urgent, because
urgent.
there is lobar collapse. Okay?
Yeah.
Okay, it's good for you about your description, but there is some additional finding. If you look here, 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 everywhere here, you can find some pleural plugs of calcification. Okay, but here you have this left lower lobe collapse. This the modality of the report. By the way, this case from the RCR site. Okay, they describe like this. Okay, you have to describe triangular opacity projected over the left cardiac border with obscuration of the medial hemidiaphragm and loss of volume left hemothorax. You can write appearance escaping with left lower loop collapse. Also, multiple calcific plaques indicating asbestos, previous asbestos exposure. No pleural effusion, no destructive bony lesion to exclude any metastatic lesion to the bone. You can add no pneumothorax. So in the diagnosis part, you have to write this appearance suspicious for central lung cancer because the patient is 81. Uh, Also, other endobronchial lesion, including mucus plugging, are possible, but you have to put the possibility of lung cancer and the management of lung cancer. Okay, no problem to put mucus plugging as a differential, or you can ignore. Okay, because the most important thing and the most common thing in this age group is lung cancer. So urgent CT chest and upper abdomen to further investigate, and urgent chest clinic review. You can add also patient may need endobronchial biopsy for the lesion, or you can leave. Okay.
Okay.
Here, your next case, 18 years old female referred from GB, painful left knee.
Okay. I'm presented with the frontal and lateral radiograph of the left knee joint. Okay, I'm looking at the radiograph. It was the frontal radiograph. I can see the joint spaces appears to be normal. The patient has presented with a history of pain I'm looking at the soft tissues as well, bones.
Okay, think loudly. Tell me what are you
Uh,
thinking about? How will you tackle the knee radiograph? Tell me.
uh, yeah, I can see there is some subchondral deficiency noted along the medial femoral condyle. Uh, Settle with a surrounding area of sclerosis. Uh, I'm suspecting to be a osteochondral defect, osteochondral lesion. Uh,
Okay,
I will further go with the MRI of the knee to further characterize the lesion and to see the uh, 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 whether this osteochondral lesion is stable or unstable. And I will then refer the patient to the orthopedic department for further management.
okay. If you
Injection,
if you see osteochondral defect in knee joint, then what are you searching about more? What's the complication?
complication, maybe it
Okay,
can lead to uh,
detached bony fragment. Can you see any detached bony fragment here?
mm, no, I can't see.
Okay, so in this case, we have this Leucent area with central sclerosis along the medial femoral condyle, which is the most common location for osteochondral defect. But if you look here, you will see detached bony fragment. If you saw this area, it will be large and small area of sclerosis. Whatever the finding, you have to search for any detached bony fragment. Okay, in any knee joint for any musculoskeletal radiograph, you have to go like this with the bone, like this. Can you see my mouse?
Yes, I can see.
Okay. With the cortex of the bone, every bone. Okay, so I will go here, see the spine, see the medial tibial plateau, go with the cortex here. I will go here with the with the fibular head, and here, and I will see the medulla, any central lesion, any calcification, and I will see the patella. Okay, if you look like this, and you will see the joint space. If you go like this, and then the soft tissue, you will not miss any lesion. Okay, so this case was an osteochondral defect in the lateral aspect of the medial femoral condyle, and there is a bone fragment centrally within the joint space, no joint effusion, so an MRI and urgent orthopedic referral for this patient. Okay, thank you, candidate one. Candidate two,
Thank you,
please.
sir.
Can you unmute yourself?
Yes, I am available.
Okay.
Assalamualaikum.
Alaikum assalam wa rahmatullah. Your case, first case, newborn male referred from neonatal unit. History of traumatic birth due to shoulder dystocia, query, clavicular fracture. Okay, you can go ahead.
This is the X-ray chest frontal projection of skeletally immature child, newborn male patient, which is referred from the neonatal unit with the history of shoulder dystocia. I'm looking for any evidence of any clavicular fracture, but both clavicles appear normal. On the X-ray, I can appreciate that the heart appears to be mildly enlarged with the slightly elevated apex. However, the lung fields appear unremarkable. However, there is slightly reduced vascularity in the left lung. I can appreciate there is a NG tube in situ, which is appropriately placed. I'm suspecting I'm looking at the shoulder joints.
Okay, how do you look at the chest radiograph? Can you tell me your check areas?
First, I will look at the lungs.
First, you have to check lines and the tubes. Okay.
Lines and tubes. Yes.
Okay. Second thing.
Second, then I will look for the lungs, chest, lung
Okay.
filling.
How do you look at the lungs?
I will compare the both lungs.
Okay. Can you compare this both lungs, please?
Yes, on in this X-ray, I can appreciate few lucencies in the right lung. However, the left lung, reticulations in the right lower zone, and left lung appears
Which
to
lung
be
is abnormal? Which lung is abnormal? Hyperlucent or the right or left?
I think the right lung is abnormal with the.
Why?
Because I can appreciate few linear capacities in the right lung. I'm suspecting some reticulations and coarse.
Okay. What's your opinion about left cardiac border and right cardiac border?
Right cardiac border appears to be slightly irregular as compared to the left heart border. So I'm thinking about any.
Okay. Look at those costophrenic angles and compare.
Both costophrenic angles are sharp. However, the
Okay.
left
No
lung
problem.
appears to be more lucent as compared to the deep sulcus
Okay.
sign on left side.
Okay. Okay.
There can be suspicion of pneumothorax on the left side.
Okay.
So I will correlate findings with the history. If I think there is left side pneumothorax.
Okay. How will you manage?
I will refer the patient to the chest clinician who will check for air entry.
Patient is neonate.
Neonatal unit for clinical examination. If there is decreased entry, I will urgently refer this patient to the neonatal unit for the chest tube intubation for the pneumothorax.
Okay, no problem. This case, typical exam case. Okay. By the way, this is not like viva. You will tell me this finding. I will tell you like look here, look here. You are alone with the image. Okay. Put this space in front of you. Please, every case, exclude safety points first. Okay. Chest radiograph. I have to exclude any pneumothorax. Okay. By the way, because of all of the neonate will take supine, if you look at the edge of the film here, they told you supine. It will not like the adult one. So you have to search for signs of pneumothorax in supine position, which is deep sulcus sign. Okay. If you look here, you will see the left lung field is more lucent than the right. You will compare by the vascular marking. Here, the vascular marking are normal. You can look here to cardiac lesion are like normal. But if you go to the periphery, no vascular marking. And if you concentrate more, you will see some pleural line faint here is seen, and deep sulcus sign, and sharp left hemidiaphragm, and sharp left cardiac border. Okay. All these signs are of neonatal pneumothorax. Okay, so
Okay.
key practice on this point. You have to comment on the tubes first because you will forget to comment on in the exam stress. Okay, because sometimes the only abnormality about lines and the tubes. Okay, so model answer for this one: nasogastric tube passes into the stomach, tip is not visualized. Increased transradiancy of left hemothorax with pleural edge seen infibulaterally. No mediastinal shift. Right hemothorax is clear. No fracture or dislocation. Normal heart size. My diagnosis is left pneumothorax. No evidence of tension. So I will urgently phone the neonatal unit to ensure the findings are known. Consider chest drain insertion, particularly if a patient under stress. Okay. Okay. Your second case, 20 years old male patient presented to A&E by cuff.
This is the X-ray chest frontal projection of 20-year-old male patient with complaint of cough. I am looking at the lung fields. Both lung fields are are normally appears to be of normal volume, and I cannot appreciate any opacity in the lung fields. However, in the retrocardiac area, there is suspicion of an opacity in the retrocardiac area just below the left hilar region. Bilateral pulmonary vessels appears normal. The cardiomediastinal contour is normal. The trachea is central in position. I can appreciate continuous diaphragm sign, which is so I'm concerned about, as well as I can also appreciate some linear lucencies extending into the superior mediastinum. So I'm concerned about pneumomediastinum. Bilateral, I cannot appreciate any evidence of pneumothorax. Visualized bones appears normal. So as the patient presented in the emergency with the complaint of cough, I'm suspecting any esophageal.
Okay, you don't have to interpret your finding. Please tell me your management.
I will urgently inform the findings to the referring clinician and refer the patient to the chest physician for the further. I will advise further CT chest for confirmation and to rule out the cause and refer the patient to the chest physician for the management, urgent management.
What will be the management for this patient? CT done and confirmed pneumomediastinum.
If there is no pneumomediastinum, then
There
patient
is.
can be followed up. There is. If there is pneumomediastinum, then the cause should be ruled out. If and that cause should be treated.
What's the cause? Expected
If
cause.
there is any esophageal perforation, so esophageal repair
Okay.
can be referred for this esophageal.
But if no esophageal perforation, what will be the management?
Then patient can be followed up
Okay.
for any distress.
Okay.
If the patient
Okay.
is stable, then
Conservative management. Okay.
yes.
For this patient, first of all, okay, you have to go for the lungs. Lungs are clear. I couldn't detect any pneumothorax. Bony skeleton is good. Spine also is good. Cardiac size is good. So I will look for the mediastinum. You have to look for pneumothorax, pneumomediastinum. Okay. Signs of pneumomediastinum include there is air lucences are extending along both paratracheal lines in the superior mediastinum. And if you look here at the aortopulmonary window, there is air extension. And you can see also there is air lucency here on the left side, and there is continuous diaphragm sign. Okay, so this is a case of pneumodiastine. So after the description, you have to urgent inform the referring physician about the finding. Patient should be kept under observation with treatment of the primary cause if there is. Okay, if there is any suspicious of perhaps syndrome, which causes esophageal rupture. By the way, it is more common in old patients. Okay, for this young patient, the cause of mediastinum may be this Mecklin effect, those small bully rupture and the air tracking the interlobular space to the mediastinum. The most common cause. A patient may need, you have to tell, may need CT chest if not improved. You don't have to tell, I will do CT chest for confirmation. Are you sure this pneumodiastinum or not? Can two?
Sorry,
Are you sure? Are you sure this pneumodiastinum or not?
Yes, on X-ray this is sure, because there
Okay.
is a definite continuous diaphragm sign.
Okay. So no need for CT except if the patient is not improved or follow-up study demonstrate increased pneumodiastinum or the patient underwent stress. Okay, so you can write like this: patient may need CT chest if not improved to be safe radiologist. Okay, thank you. Can two? Can see?
Yes, sir, I'm available.
Yes. Okay. Can three? This 30 years old male patient presented with pain.
Okay. This is a X-ray of pelvis of a skeletally mature male patient. I'm looking at the bones. The femur is the right femur is normal. The left femur is also normal. The iliac bones on both sides appear normal. The sacroiliac joints are normal. I am looking at the pubic rami, and there's no abnormality. There's no obvious abnormality of the pubic rami or the ischial tuberosities. The sacrum is also intact. I can see within the soft tissues, I can see there's some lucency around the urinary bladder wall, urinary bladder, which might represent emphysematous cystitis. I will I will get a CT scan of the pelvis done.
Okay. Ignore about the urinary bladder.
Okay.
Anything else?
The mm, there's some lucency around the around both the hip joints, which might
Okay. Okay. No problem. No problem. For the pelvis radiograph, you have to go by rings. Okay. This internal ring, go here, 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 rapidly. Okay. Nothing.
Yes, sir.
This external ring, go here, 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 go here. Nothing. Okay. Shenton's
Yes, sir.
line here on the left side. Preserve it. Okay. Shenton's lines on the right side. Can you observe anything here?
So there's a triangular radio density projected over the medial aspect of the female right femoral neck.
Okay.
Uh, so this might represent a stress fracture.
Okay. Then
Mm,
what will you?
I will get a bone scan done to get to see if there's
Are you sure
increase.
this is stress fracture?
No, sir, I'm not.
Why? What could be else?
It might be a sclerotic bony lesion, although it should
30
be
years old male patient.
mm, it can it be infection?
Okay, no problem. About this case, okay, we'll go by all rings here, but if you will go with the Shenton's lines, you have to check the femoral head, femoral neck, like here. Okay, so this stress fracture. Okay, for the stress
Okay.
fracture, what is the management?
Sir, the management of stress fractures is to rule out the cause of the stress fracture, maybe some rest.
Okay, conservative management. Okay, so
Yes.
this case, there is how to describe sclerotic line through the inferior aspect of the right femoral neck, subtle periosteal reaction, which is this here, no other
Yes, sir.
abnormality. Okay, right diagnosis, right femoral neck stress fracture, orthopedic
Yes.
opinion for rest and conservative management. Okay, no
Okay.
more. Okay, no
Yes.
need.
Yes.
We may recommend MRI, but no bone scan. You will do bone
Okay.
scan for stress fracture? No. Okay, you try
Okay.
to be more safe. Second case. Okay,
Okay, sir.
neonate with respiratory distress.
I'm provided with X-ray chest of a neonate with respiratory distress, in which I can appreciate there's a central line um, going from the right side into the chest. I cannot appreciate the inferior aspect of the it's projected over the
Okay,
yes.
ignore about this, not central line, it is oxygen tube
Okay, sir.
because it
Okay, sir.
extend outside. You see, if you see here, you have to, any line, you have to trace the line. Okay, you will go
Oh,
here.
yes, sir. Yes, sir.
Okay,
Yes, sir. I see it now.
okay, okay.
Uh, there are cystic lucencies within the right hemithorax, which shows increased volume. There's
Right or left?
sorry, in the left hemithorax I can appreciate cystic lucencies. The right hemithorax also the left hemithorax also shows increased volume, with a mediastinal shift towards the right side.
Okay.
The trachea is also shifted towards the right side. So the cardiac these lucencies are small, are in order of 1 to 2 centimeter, 2 to 5 millimeters in size, and do not conform to the configuration of bowel. So this is probably a case of cystic adenomatoid malformation. I will, with other possibility of congenital diaphragmatic hernia, although I can see I can see the diaphragmatic contour on the on the left side. So I will get a CT scan of chest done to confirm my findings and refer the patient to the neonatal to the pediatric surgeon for management of this patient.
Okay, well done. For this case, okay, you describe it very well. You put differential, it's very good. Okay, you tell everything about the lines, which ignore if you don't, you have to trace the line. So, oxygen tube noted, multiple cystic areas through the hyperinflated left lung, causing mediastinal shift to the right, pneumothorax, areas of linear sequential space shadowing left phase. Right lung is clear, so diagnosis is congenital pulmonary airway malformation or CPAP. You can put differential in this case. Differential logic, maybe pleuropulmonary blastoma or congenital diaphragmatic hernia. So you have to review in previous radiograph. You have to insert any GT tube because if there is any diaphragmatic hernia, it may go up in the chest. Refer the patient to pediatric surgical because both of the cases are surgical management. And preoperative CT scan of the chest may be required. Okay. Thank you, candidate 3. Candidate 4.
Yes, doctor, I'm here.
How are you?
I'm fine, thank you.
Okay. Your first case, neonate with abdominal distension.
Okay, so this is frontal radiograph of the abdomen for a skeletally immature patient. Curvilinear lucencies are seen along the walls of the central bowel loops, small bowel loops. Okay, and there are no fluid, air fluid levels, no pneumoperitoneum, no portal venous gas, no distension of the bowel loops. However, there is paucity of bowel gas in the periphery of the film and the large bowel and in the rectum. Bones are normal. Okay, there is a catheter inserted into the urinary bladder, probably in the proper position. My principal diagnosis in this case is necrotizing enterocolitis. Differential diagnoses include infectious causes of colitis, other infectious causes, or meconium ileus. However, this is unlikely given the presentation of the patient as well as
in short cases.
Yep.
If the diagnosis is obvious, no need to put differential. Okay?
Yeah, exactly. Okay, so my management would be urgently find the NICU to inform them of the findings and results. They should monitor for signs of perforation, NG tube, MPO, IV fluids, antibiotics, and pediatric surgery, urgent referral, and consultation. Yeah.
Okay. Thank you. By the way, the air lucency is here. Okay, on the left side. You see? Can you see my mouse? Can you hear me? Candidate 4? Candidate 4? Okay, my voice is clear. Other candidates?
Sorry,
Okay.
doctor, I lost the connection. I joined just again.
Okay, no problem, no problem.
Okay.
By the way, the air lucency in the wall is here on the left side. Okay? If you can see my mouse. Okay? You committed everything. So it is a case of necrotizing enterocolitis. So dilated bowel loops in the left iliac fossa with peripheral linear lucencies, prominent gastric bubble, normal caliber of central lobe bowel, no definite free gas. So necrosis. You have to tell also you can consider lateral decubitus to exclude associated pneumoperitoneum. Okay?
Yeah, exactly.
Otherwise, neonatal ICU care required. You have to, if the patient is not in the neonatology unit, you have to shift the patient to neonatology unit. We may need pediatric surgical opinion, cessation of oral feeding, NHD2. Okay?
Sure.
Okay, your second case, adult female patient with chronic cough.
Okay. Chest radiograph for an adult female patient, frontal projection. bilaterally almost symmetrical enlarged hila, and right paratracheal soft tissue or strip thickening. Bilateral reticulonodular shadowing in both lungs. Lung volumes are preserved, no pleural effusions, no mediastinal shift, normal cardiac size, normal bones. Features are consistent with the granulomatous disease. Principal diagnosis sarcoidosis, differential diagnosis tuberculosis, lymphoma. My management would be reviewing of previous images if available, serum ACE and calcium levels, urgent referral to, or no need for urgent referral, it's only referral for respiratory team and MTD discussion. If the findings or laboratory findings are not consistent with sarcoidosis, then CT scan would be informative.
Okay, thank you. Well done.
Thank you.
So this is a case of bilateral bulky hila. Okay, right, left, and the right paratracheal. Now it's Garland triad. Okay, and there is also reticular obesity in both lungs, more predominant at the upper lung zones. No other abnormalities. So it's a case of sarcoidosis. We can put, as you did, differential like lymphoma or lymph node metastasis or tuberculosis. So, as you told, review previous imaging, if any, further testing with ACE enzyme level, CT chest, referral to pulmonology MDT. The patient may need transbronchial biopsy for lymph node. Okay, thank you. Well done. Next candidate.
Yes, good evening.
Good evening. How are you? Okay. Your first case, 40 years old patient with pre-employment chest radiograph.
Okay, this is a frontal radiograph of an adult patient where I can see that there is a large opacification seen within the center of the chest. Has a I would say an oblong shape, and it is elongated, extending down into the upper abdomen. And I can also see it's it's obscuring the left hemithorax. The right hilum is enlarged. There is also an widening in the superior mediastinum as well, with a soft tissue mass-like lesion.
Okay, where is the lesions? Localized.
Yeah, I think there are one within the superior mediastinum, and there is another opacification in the mid and lower mediastinum as well.
Which part of the mediastinum?
I think it's the anterior mediastinum. Is
Why?
I cannot see the left cardiac border. At least it's upper part of the left cardiac border. I cannot see separate from the mass.
Okay, what's your differential?
Okay.
Anything else, by the way? Anything else?
There is reticulation in the I can see within the lung parenchyma on the right side.
Okay, anything else?
Okay. No.
What are your review areas?
The apices, which looks free, and the mediastinum is the hilar. Sorry, the hilar is bulky on the right side, and no pleural effusions. Radiocardiac, the retrocardiac area cannot be seen clearly, and the bones look it looks clear, no obvious abnormality I can detect within the bones.
What's your differential management?
Okay, I'm thinking of a mediastinal lesion. It could be a an achalasia because it
No.
have
Okay, no problem, no problem. Okay. About this mediastinal masses, okay. If you see here, this mass is extending above the clavicles, which means here
anterior mediastinal mass.
anterior will extend above the clavicle.
Well, I think both of them might extend above the clavicle, but if I cannot see its upper border, then it would be an anterior mediastinal mass. And in this one, I cannot see its upper borders.
Okay. The next one, this one, can you see this left cardiac border or not?
Yeah, I can see it
Okay,
now.
so
So it's not an anterior mediastinal mass.
okay. Can you look at the bone? What's your opinion about this ribs? Is normal?
It's widened. Yeah, it's widened.
Yes. Okay.
Yeah,
Can you look here? The
yeah.
acromion. What's your opinion about the acromion?
I think it's lucent and widened as well.
Okay. So what's come in your mind now?
It could be a case of a neurofibromatosis.
No. This is a case of multiple posterior mediastinal masses with rib expansion. So what's your definition?
Like schwannomas.
No, it is a chronic.
Extramedullary hematopoiesis.
Yes. Chronic hemolytic anemia, okay, and extramedullary hematopoiesis, okay?
Mm-hmm. Yeah.
So you have to describe smooth contoured bilateral superior mediastinal soft tissue masses extending above the clavicle, cervicothoracic sign present, large soft tissue masses in the left hemothorax, hilum overlay sign present, left cardiac border clearly delineated. So it is anterior posterior mediastinum, additional soft tissue in the right hilum, and also you can see the right hilum overlay sign also on the right side, okay? Rib expansion, so extramedullary hematopoiesis secondary to thalassemia, okay? Your management, hematology referral, genetic screening, CT chest to confirm the X-ray. By the way, now all the modalities, short report, long cases, viva, you can practice all in the same setting, okay? Not like before, chest radiograph, some nodule, some pneumothorax, some subtle finding. No, now you can find long cases, okay? But you have to describe in short report. But only one modality. Long cases, multiple modalities. Viva, you may face one modality or multiple modalities in the exam. So it is a good thing for you. So because you practice everything with everything, okay? So this case may come as a long case, but with CT may come when Viva exam also, okay? Okay, your second case, this 65 years old female patient with gradual onset of shortness of breath.
Okay, this is a frontal radiograph of an adult patient showing there are I can see there are bilateral reticulations seen in both hemissources in the mid and lower zone. Reticular thickening in form of reticular thickening. There are also multiple nodules, I can say, seen in the hemithoraces in both scattered.
Okay.
I'm not sure. There is a blunting of the right costophrenic angle. It could be a pleural thickening or a small pleural effusion.
Okay.
Okay, I'm looking at the bones.
Very good.
Where I cannot
compare, please. In bones,
okay.
please compare.
Okay. Okay, there is in I think there is around this sclerotic lesion seen in the right humerus. I'm not very sure of it. And
If you find
mm,
multiple pulmonary nodules, bilateral
mm,
pleural effusions,
mm.
female patient, you are looking at the bone. What are you looking for?
I'm looking for metastasis if there is any
Okay.
sclerotic metastasis.
Please compare both sides. You will look at the ribs, look at the clavicles, look at the humeri, look at the
Yeah, I'm looking at them.
scapulae.
Okay. Actually, the image is slightly blurred. I don't know.
I know, image is very bad, okay?
No,
But
no,
have
it's
you,
not the image. I think it's my connection. It's
whatever,
just
whatever, but you have to accommodate yourself in the exam. Maybe
yeah,
sometimes the
yeah,
film is not good, okay?
yes, yeah,
But after you found the pathology, you will find it very obvious, okay?
yeah.
Okay, concentrate on the scapula, please. Can you see any abnormality?
Yeah, I looked at it, to be honest, several times. I cannot detect it. I think there's a lytic lesion on the right scapula. Yeah.
Okay,
Um,
give me
ex-
your diagnosis management.
um, my diagnosis, so, I'm thinking of metastasis into the
Okay,
bones and to the lungs.
okay,
I look at the breast shadows, both of them, and they look relatively symmetrical, and I couldn't
okay,
find any surgical clips to indicate a previous mastectomy. However, I would still look at the patient's previous data and if there is any non-primary. Else, I would recommend CT, chest, abdomen, and pelvis
okay.
to look for the primary and
What could be
distant.
the primary in this patient?
Breast is
Okay,
my first differential, then it
okay.
could be from
How?
the lungs.
Okay, breast. How will you manage? 65
Um,
years old female, and common to be breast than lung. Okay,
yeah, yeah.
okay.
For
How
the
will?
breast, yeah, I will do CT, chest, abdomen, pelvis, and I will send the lady for the breast clinic an urgent arrangement review within the breast clinic.
Okay. I think it's white, but I think no difference between the both images. Okay.
Mm, mm,
This is a CT for the patient. Okay. This
mhm,
breast mass, pleural effusion bilateral, multiple nodules within the both by lung parenchyma. So our first possibility will be metastatic breast carcinoma. Okay.
mhm,
So as you told, triple assessment of the breast to refer to discussion at breast cancer MDT. You can put differential in this case, by the way. Okay. Because you are not sure it is breast or not, but you have to put because the patient age, because patient gender, you can add another thing, but as a differential, okay? But if you didn't put the breast in this case, you will lose marks, okay?
mhm, mhm.
Because she is a female patient, okay? You will
Yeah,
do complete staging, CT, abdomen, and pelvis, uh, because the patient already did the CT chest, and consider nuclear medicine bone scan if there is another bone metastases, and you can consider orthopedic opinion regarding lytic scapular metastasis, okay?
yeah,
Uh, Thank you, candidate
yeah.
5. Candidate 6.
Good evening, sir.
Good evening, how are you? Okay. Your first case, chronic hand pain.
Okay. This is frontal radiograph of both hands. There are symmetrical joints, spaces narrowing of the interphalangeal joint of the both hand and carpal joints as well, and radiocarpal joints. No obvious bone erosions, no soft tissue thickening, but I can see some soft tissue calcifications around the joints, especially in the right, second, and third metacarpal joints, metacarpal phalangeal joints. The metacarpal, phalangeals of the both hands show some reticular shadowing. Cortex are thinning. No pathological fractures.
Anything are you concerning about?
I think this is a sarcoidosis.
No, no. It's not. Sarcoid is lace-like bone. Okay. What are your check areas and hand radiograph?
Soft tissues and distal end, no acrolysis.
Okay.
But
Good.
I can see some soft tissues, subtle soft tissues calcifications.
Where?
Around the right,
Around
second
the
and
joints.
third. Yeah, around the joints.
Okay, okay, no problem. Anything else?
I don't see
Okay,
more
what
erosion.
common pathologies are you expecting in hand radiograph?
Arthritis.
Okay, no arthritis.
Sorry, sir, no arthritis.
No arthritis.
Okay, this could.
You told acrosteolysis, okay? What else?
It could be.
Okay.
Yeah. And also.
What about hyperparathyroidism?
And
Did
also
you
this
exclude?
could be, yeah, I'm looking for the cortical erosions to exclude hyperparathyroidism.
Okay.
In my clinical practice, I will zoom out especially in the medial phalanx, radial end, to see whether there is any subtle erosions.
Which side, radial or ulnar side?
Radial side.
Okay, look here. Any subarostal bone resorption? Here.
There are some subchondral erosions. Yeah, this is hyperparathyroidism.
Here. Okay. In the exam, you will not find all the lesions typical. Not all. You can also to look for the dialysis fistula or anything like here. This okay, but subtle finding may be present. Okay. So it is a case of hyperparathyroidism. Okay. So your description: subperiosteal bone resorption, the radial aspect of the pharynges, particularly involving middle pharynges, more marked on the right side. Chondrocalcinosis, triangular fibrocartilage, some soft tissue calcification, no vascular calcification, no AV fistula. Okay, this is pertinent negative because if there is AV fistula or vascular calcification, you will tell secondary hyperparathyroidism. Okay, so here primary hyperparathyroidism. What's your management?
Yeah, giving the findings to the referral clinician, and this patient need endocrinological referral and also need blood investigation correlations.
Serum calcium, serum birth hormone. Make ultrasound and systemic scan for parathyroidism. Okay.
Yeah.
They also check any previous history for any renal dialysis like this. Okay. Okay. Your second case, 10 years old female patient with hip pain.
Frontal radiograph of a pelvis. I can see the abnormality in the right hip joint. The humeral line is not dissect the epiphysis. So, and there is a no significant. Sorry?
What line did you mention?
Femoral line, yeah. This upper femoral line, yes. Does not dissect the lateral part of the epiphysis.
Klein's line, yes?
Yeah.
Okay.
And the epiphysis, the contour of the epiphysis looks normal, and hip joint space are maintained, and left hip joint is maintained. And so the other bone, no sinister other bone lesions. So this is the conclusion is right. Superior upper femoral epiphysis, slip upper femoral epiphysis.
Okay.
And management, the fog view of both hip joint because it is commonly associated with bilateral hip joints. So a fog view of the both hip joints, and I'll give my findings to the referral clinician, and this patient need to be seen by orthopedic team for management of the hip joint.
Urgent or not?
Sorry?
Urgent or not?
This is urgent.
Okay. What type of fracture is this? Fracture?
Is Harris fracture 1.
Salter Harris 1.
Salter
Okay.
Harris fracture 1.
Okay. What could be the management the orthopedician will do?
They usually fix both hip heads, epiphysis and the neck with a screw. There is a name I can't remember, to prevent the further osteoarthrosis like that. So usually do bilaterally.
Okay. Well done. Okay. In this case, we did the frog position. It confirms the diagnosis of slip upper femoral epiphysis on the right side. Left ones appear normal. What is this?
It is protector, radiation protector.
Okay, gonadal shield. Okay. In the description, there is posterior medial slip of the right upper femoral epiphysis with widening and the regularity of the physis. Left side, you have to comment on the left side, by the way. Left side appears normal. Rest of the bone of the pelvis appears normal. So diagnose slip right upper femoral epiphysis. So inform the clinician immediately. Check if the pain is present the left side as well. Refer urgent refers the patient to orthopedician for further management include binning. Okay. MRI pelvis may be indicated if the pain is bilateral to detect the trophy on the left side. Okay. Okay. Thank you, candidate 6. Candidate 7.
Yes.
Okay. 10 years old patient with tender swollen forearm.
Okay, this is a frontal and lateral radiograph of immature respiratory patient, swollen for our 10 years. There is evidence of abnormal extension of the bone of the left ulna in the proximal shaft. There is evidence of some lucency or some sort of lucency noted within this lesion, within this expansion. I can appreciate also that there is evidence of soft tissue swelling surrounding. There is evidence of there is evidence of periosteal reaction noted, no evidence of pathological fracture. I can appreciate that there is evidence of wide zone of transition. Okay, my principal diagnosis for this would be osteomyelitis of the forearm. Differential diagnosis could be aggressive bony lesion like osteosarcoma or Ewing sarcoma. I would urgently refer this patient for the orthopedic team. I would arrange also for MRI for accurate evaluation of this. I would also ask for the ESR and C reactive protein for evidence of increasing inflammatory markers. If this proved aggressive bony lesion or sarcoma, I would send this patient for sarcoma center for biopsy and refer for immediate and CT.
In the short exam, you have to put priority, okay? And then the management upon. You will not put management for osteomyelitis and management for sarcoma, okay?
Okay.
So you have to go with history, with finding, and then recommend one and upon the management, okay?
Okay.
Because it's short reporting, you will not write everything, okay?
Okay.
Okay, well done. So it is a case of osteomyelitis. By the way, this image after 1 year. Okay,
Okay.
so it turned into chronic osteomyelitis. But there is lucent, slightly expansile lesion in the proximal ulnar metaphysis extending into the epiphysis, which shows wide zone of transition, thick, dense, solid appearing Brewster reaction surrounding the lesion, no pathological fracture, no soft tissue mass. Your diagnosis acute osteomyelitis, differential diagnosis is eosinophilic granuloma and Ewing sarcoma. So, alert referring physician of the finding, recommend discussion at pediatric orthopedic MDT for further management. Okay. Your second case, shortness of breath.
Okay. This is the frontal radiograph, mature skeletal patient chest. I can appreciate that there is evidence of bilateral opacity in both lung parenchyma. The opacity appears to be extended through from the upper to the lower zone of the lung. I can appreciate that there is opacity in the right upper apical zone. Okay, I can appreciate that there is evidence of calcified plaques noted through the pleura, and there is also evidence of calcified plaques within the left hemisthorax and noted also within the diaphragmatic pleura in the right hemisthorax. I can both costophrenic angle appearing normal. The mediastinal appearing normal, the trachea appearing in the midline. I couldn't see evidence of pneumothorax, the bone appearing normal. My diagnosis for this would be a mesothelioma. It could be a mesothelioma, or asbestos exposure and mesothelioma. I would
Where is the mesothelioma?
specifically in this opacity in the right upper hemisthorax. It could be thickening pleura, marked thickening of the pleura.
This one.
Yes.
Is it smooth or nodular?
It's not too much clear for me, but it could be smooth.
Okay.
Okay. So
Anything else
just
other than that?
I'm trying to look other than in the base. Yes, in the base there is in the base of the right lung there is some calcified nodules.
Okay, you told there is
Yes.
calcification
Yes.
here, calcification here, calcification here,
Yes.
calcification. Okay.
So
Other than calcification.
other than calcification, it's reticulation that scattered through both the lung parenchyma appear to be more in the base.
Okay, what's your opinion about this region?
This could be a mass on top of this. Um, could be a mass in the lung on top of lung fibrosis, maybe due to asbestosis exposure. Could be fibrosis, but fibrosis with asbestos exposure would be more in lower zones rather than upper zones. So I don't.
Okay.
I'm
No
thinking of mat
What
on
could be this possibility, this opacity? What could be the possibility of this opacity? This one.
This one could be pleural thickening, or it could be a mass. I'm really
Mass is here. This homogeneous mass will come homogeneous like this.
no, and the bone also is normal.
What else? Okay. This right upper loop collapse. Okay.
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 Because there is no shifting of the trachea, no, yeah.
There is some shifting here, and the trachea. If you see the trachea, there is shifted also to the right side.
Yeah.
Asbestos is incidental finding. There is mass here, speculated mass. So, give me your diagnosis and your management steps.
So this is a case of right upper lung zone aggressive neoplastic lesion with collapse of the right upper lung loop. This and incidental asbestos exposure. I would urgently convey this finding for the referring physician. I would arrange for CT with contrast, CT chest with contrast, CT staging. I would refer this for MDT for discussion and biopsy. And at the same time, I would also ask for the exposure history for this patient.
Okay, thank you. So this patient, there is homogeneous opacity in the right apical zone, speculated mass seen in the right upper zone adjacent to this, decreased right lung volume, mediastinal shift to the right, multiple calcific plate, pleural flex, bulk right hilum, costophrenic angle normal, no pleural effusion, normal cardiac size, no focal bone lesion. Okay, so right upper lobe collapse secondary to upper zone hilar mass, compressing the mass, compressing the upper lobe trachea. Asbestos related lung diseases later finding. So as you told, CT chest, abdomen and pelvis. Refer to lung cancer MDT and plan for biopsy. Okay, thank you. Candidate 8.
Assalamu alaikum, sir.
Walaikum assalam. Okay, your first case, 42 years old female with cough.
Frontal chest radiograph of 42 years female who presented with cough. There is an opacity in the right hilar, parahilar location. It is rounded and surrounded by lung parenchyma on all sides. There is a bulky adjacent hilar region as well. No evidence of any breast asymmetry, any under lung nodule, no CP angle blunting, no bony lesion noted. Differentials include round pneumonia or parenchymal lung parenchymal
Round pneumonia in 42 years old female patient.
Yeah, less likely.
Round pneumonia in a child only.
Okay.
Okay.
So differentials include lung mass or an intraparenchymal lesion, or if the patient has recently suffered from any infection, it can be a pneumatocele. But I would also like to check past history to look for any liver hydrated disease, although I cannot see any calcification within the lesion, no fluid level. Another possibility can be a large pulmonary AVM, but it is unlikely to be that big in size. So I will advise CT chest with contrast for further correlation.
What's your diagnosis? And give me diagnosis, please. Benign lesion. Okay, what could be? You told hydatid cyst. Okay.
Yeah, a pneumatocele, or it can be carcinoid.
Pneumatocele will be
less
dense?
likely to be this much big and dense. Less likely.
Okay. Anything else? Most common benign lesion in the lung.
Carcinoid or hematoma, carcinoid.
Okay.
Yeah.
Okay, it is hematoma. This is the CT of the patient. There is calcification inside. So it is a benign lesion, well defined, rounded, soft tissue density, projected over. If you see here the hilum vessels, you can see through the mass. Okay, so it is not likely, less likely to be AVM or like this. Okay.
Okay.
So right lower lobe pulmonary artery separate from the mass, no other abnormality, no bony lesion. So right middle lobe hamartoma. Differential may include bronchogenic cyst. Discussion at lung MDT. Consider excision if patient symptomatic. Okay. If conservative management, you can follow up by radiograph. Okay.
Okay.
Okay. Your second case, elderly patient with shortness of breath.
A frontal chest radiograph of an elderly patient who presented with shortness of breath. There is a reduced lung volume on the left side with the shift of the trachea and mediastinal structure towards the left. Some blunting of the CP angle noted. Left upper lobe shows an opacity with a prominent lucency adjacent to it. There is a peripheral lung pleural base lesion noted as well. Findings are concerning for left upper lobe bronchial mass with a deposit in the left chest wall. There's some pleural effusion associated with it, which can possibly be malignant. Rest of the lung do not show any abnormality, no rib lesion noted. Cardiac size is within normal limit. So findings are in keeping with left upper lobe mass with left upper lobe collapse and a metastatic deposit in the left chest wall. I will advise.
Can you see the mass in this planar radiograph?
No, I can't see the mass, but there is an abrupt cutoff at this level.
Okay. What is this sign, please? This one?
So this is in keeping with left facial sign.
Okay.
And, so I will advise a urgent CT chest, abdomen, pelvis. I will expedite the process by a 2-week bed pathway. I will refer the patient to respiratory oncology MDT and would like to compare with the prior radiographs if available as well.
Okay, thank you. So it is left upper lobe collapse, veiling of the left lung fields, left facial sign, decreased left lung volume, elderly patients. There is some reticulation here. No any bony lesion, no other lesions on the right side. So it is left upper lobe collapse, most likely due to endobronchial carcinoma in elderly patient. Okay. You have to put carcinoma in the exam. They will not bring for you case to write mucus plugging or something like this. Okay. So as you told, inform referring physician, fast track, CT chest, abdomen for staging, refer to lung cancer MDT. Okay. Thank you, candidate 8. Candidate 9.
Yes, Dr. Assalamu
alaikum. Okay, candidate 9, 35 years old female patient with pre-operative checkup.
Okay, this I can see that there is enlarged cardiac cardiomediastinal shadow with also there is a tracheal shift to the right side, and 35. I can see that there is it's not clear, but I can see that there is some calcification noted within the at the area of the left hilum. The right lung appear clear. Right pleural space also is clear. Okay, and post breast shadow are seen. No abnormal chest wall abnormality. So I'm thinking this maybe is my diagnosis is a cardiomegaly.
Why do you consider cardiomegaly in this case?
Because there is a splaying of the carina.
Can you carina is here because you don't have the control. This is the right main bronchus and this is the left main bronchus. Can you see?
Yeah. Okay. Okay.
And what in cardiomegaly will be coarse calcified?
Yes. So I think there is widening of the mediastinum. I will consider it as widening of the mediastinum. With
Can you localize the lesion, please?
The lesion appear.
Is it mediastinal lesion, a pleural lesion, or pulmonary lesion, or bony lesion? You have to localize.
Lesion appear to be a mediastinal based lesion, silhouetting the left cardiac border. So and as the vessels are seen through the lesion, so I think this is anterior mediastinal lesion, and also it could cause shifting of the trachea to the right side. And I think also there is widening of the right paratracheal stripe as well. So it's bilateral, but it's more prominent on the left side.
Very good.
So with the calcifications seen in both bilaterally, so this may be This is perioperative check. So I think this is an anterior mediastinal, large anterior mediastinal lesion with calcification in a 35-year-old patient. I will put diagnosis as germ cell tumors. Germ cell tumor. My other differential will be treated lymphoma. I will check the prior imaging for this patient and alert to the referring clinician. This patient need to be discussed in the lung MDT and urgent CT chest and abdomen is advised.
Is it malignant tumor?
Yes, I think if we should do further assessment by CT
What
first.
is the most common lesion for anterior mediastinal?
Anterior mediastinal.
Yes.
In young patient, germ cell tumor. In older patient, will be thymic lesions, and all in both ages may be lymphoma.
Okay. This is a case of mature cystic teratoma. This is a CT post patient containing calcification and fat. But first, my advice, if you see large mass like this, take deep breath, think logic. Where is the mass? Okay.
Yeah. Yes. Okay.
You have to localize. If you localize the mass, okay, everything will be easy. If you are looking for the mass as it is a big mass, where is it like this, you will be confused and you will waste your time and become distressed and you will not find a diagnosis of easy case. Okay.
Okay.
So it is anterior mediastinal mass. As we told you here, you can see you couldn't see the left heart border.
Securing
And
the
you can see the aorta, descending aorta well, there is tracheal shifting, heart also shifted to the left side, there is pleural effusion on the left side, symmetrical breast shadow like this, okay?
Okay.
So large opacity seen with internal course calcification, separating the left cardiac border, left diaphragm, it is caused mediastinal shift to the right side. The overlying ribs appears normal, no splaying, no destruction. So anterior mediastinal mass likely to be mature mediastinal teratoma. So you have to refer the patient to cardiothoracic surgery for surgical management. Okay.
Okay.
I think chest MDT will not be managed. Cardiothoracic surgical management. Okay.
Okay.
Your second case, left shoulder trauma.
Left shoulder trauma. Okay, this is frontal left shoulder X-ray. I can see that there is acute minimally displaced fracture noted within the lateral third of the acromion, with the acromioclavicular joint is preserved. There is no other acute fracture noted in the visualized reps. No, sorry, there is a multiple fracture noted in the third and fourth and fifth rep as well. It appeared mildly displaced, acute mildly displaced. I can see there is minimal pneumothorax, minimal left pneumothorax also is noted. No fracture seen in the scapulae or the humerus. This is emergency call. I will call the referring clinician. This patient need urgent review and alert for the report. Urgent review by the cardiothoracic team and the orthopedic team as well.
Okay, thank you. Good. If you detected any fracture or any shoulder trauma, you have to look for the lung fields. If you look here at the rib, there is one fracture, second one, third one. You can see visceral pleural line here. There is left apical pneumothorax, okay, and left clavicular fracture. About management of this case, you have to inform the emergency team, okay? Obtain complete chest radiograph to look for any other pneumothorax and for flial segment, okay? Maybe the trauma on the other side, and ascertain the pneumothorax and CT chest may be indicated in severe angles, okay?
Yeah.
Thank you, candidate 9. Candidate 10. Okay. Candidate 10.
Hello, good
Yes.
evening, doctor.
Good evening. How are you?
I'm fine.
Your first case, knee pain.
Okay, I've been presented with a lateral radiograph of a patient who presented with knee pain. I'm looking through the femoral. I can't see any fracture. The retropatellar recess is normal. I can't see any retropatellar collection. I would love to see an orthogonal view.
No other view.
Okay, the bone density is normal. Knee pain. Okay, I think there's patella barger and reduced patellofemoral space, joint space.
Anything else?
I'm looking closely at the patella surface. I can't make out anything else.
Okay. I told you want to look at the bones, you have to trace the bones. Are you tracing with me?
Yes, I am.
Can you see anything abnormal? Can you see now?
Yes, I can.
Okay. Describe and give me your management.
Okay, so I can see deepening of the I think femoral lateral femoral notch.
Ignore about lateral and medial in this view, but give me your description and your.
I think the femoral notch is deepened, and it's a sign of ACL.
Okay. Okay, look at this image, please. Ignore about the words. Look at this image.
Okay, on the AP, I can see reduced reduction in the there's reduction in the lateral tibiofemoral joint space.
Okay.
I can
go
see
back for this one.
And
Yes. Here, if you look here, there is lucency with central density seen along the femoral condyle, which is impressive of osteochondral defect.
Osteochondral fracture.
Yes. Okay. On the AP view, you can see it here. Okay. So the case is well-defined small crescentic lucency along the articular surface of femoral condyle. No evidence of loose body, osteochondral defect. We will check AB view like this. Urgent MRI, urgent referral to orthopedic surgery. Okay. Your second case, knee pain after trauma. Both of your cases are knee.
Okay, so I can see a bony fragment adjacent the fibular head.
Yes.
This is consistent with the accurate sign. Suggestive of fracture of
Is
the
it
fibula.
arcuate or another?
Accurate sign.
No.
Then I can also see a bony fragment within the intercondylar notch.
No bony fragment in the intercondylar notch. It is a patella here.
Okay.
This one is patella. Concentrate on this, please. Because if you wrote arcuate lesion, you will lose the marks because it is not arcuate lesion.
Okay, so it's an oblique bony fragment that is located in the lateral aspect of the knee, aborting the lateral tibial plateau. Is consistent with a second fracture.
Yes. Okay.
And
how will you manage?
I would inform the referring physicians, and I'm advised for knee MRI because second fractures are usually highly associated with ACL disruption. So I would want to check the knee for other ACL tear. So I'd want to check the knee for other knee injuries, and then refer to for orthopedic management, urgent orthopedic management.
Okay. So we will not make any mistake in knee joint after that. Okay, this lesion, if you see the lateral tibial plateau, you will note there is a small depression, okay, related to the bone fragment. So here, if you write arcuate fracture, you will lose the marks because it is really a second fracture. Okay, so take care in the exam. Okay.
Okay.
There is curvilinear bone fragment seen parallel to lateral margin of lateral tibial plateau, reserve joint space, no other fracture seen. Second fracture, check the cross table view for any joint effusion. Urgent MRI to assess mainly ACL. Urgent referral to orthopedic surgeon. Okay. Thank you, candidate 10. Take care.
Thank you. Thank you, sir.
Candidate 11.
Assalamu alaikum.
Wa alaikum assalam wa rahmatullahi wa barakatuh. Okay, 1-year child with tender swollen leg.
Left leg radiograph. I can see a lucent lesion in the left tibia at metadiaphysis with the narrow zone of transition and cortical thinning. Lamellar periosteal reaction.
Narrow zone of transition?
Wide zone of transition with the thinning of the cortex and lamellar periosteal reaction. No pathological fracture. No other lesion can be identified. A lesion in a 1-year child in metadiaphysis with wide zone of transition.
Metadiaphysis, really? Metadiaphysis?
Yeah, more in the diaphysis.
Or pure diaphysial?
Okay.
I think it's pure diaphysial. Because you have diaphysis here, distal one clear, and the proximal one clear. So it is pure diaphysial lesion.
I will put the differential diagnosis, osteomyelitis, Langerhans cell histiocytosis, Ewing sarcoma.
Okay.
I will ask about clinical of the patient and if any constitutional symptoms like fever. Request a lab investigation inflammatory marker and request a MRI to confirm diagnosis.
Okay, you will put what first?
Osteomyelitis.
Okay. Well, it is really carries all possibilities, okay? As you told, Ewing, xenophilic granuloma, osteomyelitis, okay? So in the exam, you can put differential, okay? And you can recommend alert referring physician, recommend MRI for better assessment and discussion at pediatric orthopedic MDT, okay?
Okay.
So the description, central lucent expansile lesion in the tibial diaphysis, wide zone of transition, was industrial scalloping, significant cortical erosion, and the bridge. There is thick, dense periosteal reaction, consistent with xenophilic granuloma and differential Ewing and osteomyelitis. As we told, alert referring physician, MRI, may need bone scan, and discussion at pediatric orthopedic MDT, okay? So if the case is not clear diagnosis, you can put differential, no problem, okay? Okay. Take the clear diagnosis.
Left ankle frontal and lateral radiograph. I can see a lucent lesion with the narrow zone of transition, no pre-osteal reaction, no pathological fracture, no soft tissue component seen at the calcaneus, left calcaneus, with the central calcification. No other lesion can be identified, no dislocation in the ankle. Interosseous lipoma, the diagnosis is interosseous lipoma. Differential diagnosis may be simple bone cyst or chondroblastoma. Refer patient to orthopedic. Request MRI to confirm diagnosis, and follow up if any pain.
Okay. Intraosseous lipoma, I think it is spot diagnosis. Okay. Well-defined lucent intermedullary region with narrow zone of transition, central calcification, no periosteal reaction, soft tissue pathological fracture. You have to put all no, okay? Rest of the bone normal, no fracture. So, calcaneal intraosseous lipoma. As regarding the management, if the patient calcaneal lipoma, no further imaging required. Calcaneal lipoma is usually asymptomatic and doesn't require further management or follow-up. Only if the patient after trauma, we can ask for MRI or discussion at orthopedic immediately. Okay.
Okay. But no need for any differential.
No need. I think it is spot diagnosis because a simple bone cyst, no internal calcification. Chondroblastoma is not. There is no, okay, there is differential chondroblastoma, but not central calcification like coarse calcification. Maybe some chondroid matrix, no chondroid matrix. Maybe chondroblastoma, but will be lucent lesion only without central coarse calcification. So as regarding this lesion, I think it is typical of intraosseous lipoma. Okay? Be confident in the exam. Don't worry. If the patient is spot, if the lesion is spot, no issue. Okay? You will face in the exam all things. Spot diagnosis, differential diagnosis, some multiple pathologies. You will face everything. Okay. So don't go far. Don't go far. Not the case not simple like this. No. You will find some cases simple, some cases more need more thinking like this. Okay. So be logic with every case. Okay. Thank you.
Welcome.
Candidate 12.
Thank you, doctor.
Welcome.
السلام عليكم دكتور منير.
السلام ورحمة الله وبركاته. دكتور سامح أخبارك؟
الحمد لله.
عامل إيه يا باشا؟
الحمد لله.
Your patient leg pain.
So this is lateral. This is frontal radiograph of the left distal half of the left femur with leg pain. There is evidence of cortical thickening with industrial scalloping and evidence of intramedullary chondroid matrix lesion. No evidence of cortical breach, no evidence of periosteal reaction. This cortical thickening with chondroid matrix, I will put the possibility of low-grade chondrosarcoma as the first possibility because of the industrial scalloping. And I will check the previous imaging, recommended checking the previous imaging of this patient if this lesion is present or long-term, and the changes of the lesion. And this needs MRI imaging and also referral to the orthopedic MDT meeting for discussion.
Okay. This case of low-grade chondrosarcoma, we have to deal with low-grade chondrosarcoma as sarcoma, okay? So you have to refer CT chest, abdomen, and pelvis for staging. Refer the patient to sarcoma center MDT. Regarding biopsy for tissue diagnosis under orthopedic review, okay? As regarding the description, as you told, there is ill-defined, large, heterogeneous, mostly lytic lesion in the distal diaphysis and the metaphysis of the femur, contain punctate ring and arc calcification, chondroid matrix. Cortical thinning scalloping of the distal diaphysis, no large soft tissue mass, no aggressive pre-osteal reaction. This is a lesion in the MRI. I think it is likely to be low-grade chondrosarcoma rather than to be in chondro. Okay, your second case, abdominal pain.
So this frontal radiograph of adult patient of the abdomen, of abdominal pain. There is a dilated bowel loop seen at the central of the abdomen. I'm trying to check for any signs of pneumoperitoneum or free intraperitoneal air. However, at the right side of lower abdomen, I can see there is dense around the structure. Could be this is ectopic gallbladder stone, and also there is lucent radiating lucency overlying the visualized part of the liver shadow at the right hypochondrium.
Okay, ignore about this. Can you look at the bones?
Yes, I'm checking for the spine for any absent pedicle sign. The pedicles looks normal. The pelvic bones, the right iliac bone, I can see there is evidence of abnormal sclerotic lesion seen at the centered at the right medial part of the right iliac bone. Involving part of the right of the sacrum. This likely I couldn't see any soft tissue around it. However, this appearance, which is targeting the right sacroiliac joint, could be a case of sacroiliitis. It is unilateral because the other side looks normal. The possibilities of biogenic sacroiliitis or tuberculous sacroiliitis. I will ask about the clinical and laboratory data of this patient and recommend MRI study of the sacroiliac joints for confirming the findings, and refer the patient for rheumatology consultant for management.
You told the infective. Yes.
Yes.
Infective. Who will manage?
I think the orthopedic and rheumatology.
Rheumatology for enclosing for
chronic cases. Yeah.
Psoriatic like this. But in this case, you are suspecting biogenic or infective. You have to refer the patient to orthopedic team for antibiotic and maybe joint aspiration like this. So the involvement here, if you say abdominal radiograph, you have to also look for the sacroiliac joint, very important. You have to look at the sacral ala. As you told, pedicles. You have to look for the superior inferior pubic rami, like this, okay? If you compare both sacroiliac joint, you'll see there is erosion of the right sacroiliac joint. So you have to put differential for unilateral sacroiliitis. Most common cause will be infective sacroiliitis. So urgent orthopedic referral for joint aspiration followed by culture and sensitivity. You can add patient may need MRI if not improved after medical treatment. Thank you, Dr. Samah. All the best, inshallah. Welcome. Candidate 13.
Hello, hi doctor, how are you?
How are you? Okay. Hand trauma.
Okay. I've been okay, so we have frontal and oblique projections of right hand. So I will just follow the cortical outlines in an immature patient, trying to look for a fracture. So I'm not seeing any obvious fractures, so I'll just follow the cortical outlines.
Did you trace all the bones?
I'm tracing the phalanges. Not seeing any obvious. I think in the tip of the distal phalanx of the right hand, fifth or little finger, there appears to be an lucency in the tip of the distal phalanx. The projection is not very clear, so I think this is the site of fracture in this patient. I can also see some adjacent soft tissue swelling.
Okay.
So I would like to refer the findings to the orthopedic team, but this likely requires conservative management.
Okay. This is a classic exam scenario. Okay. Very subtle fracture, and you overcall any finding and put it as a diagnosis management like this, and you lose all marks. Okay. I will give you the approach. For any plain radiograph for MSK, please go like this. This one, this one, this one. Okay. The other one, the other one. Quickly, the other one, the other. Go like this. Can you see my mouse?
Yes.
Here, no fracture. There is subtle here. I will compare with the other. Okay, go here. Tip, base, here, here. Go here, here. Can you see anything here?
Yeah, I can see.
You can see now.
Yeah.
Okay, go here. So if you find one fracture in the exam, what will you do?
Look at the other view.
You will complete to see maybe another fracture here, and you will take half marks only. Okay. So I saw the carpal bones, spaces, no sclerosis, distal end of the radius. Confirm here and here. So what's your diagnosis now?
So there is subtle fracture line. So Solta had
buccal fracture. Buccal fracture. Okay.
Yeah.
Buccal fracture of the base of proximal phalanx of the fifth spine. Okay. So in every bone, try to trace every bone. Okay. Here, urgent pediatric orthopedic referral for conservative management. Okay. Your second case, 25 years old male patient came to A&E complaining of neck pain.
Okay, so frontal projection of the neck. Patient 25-year-old came with neck pain. So I'm looking for the bony outline. Not.
Okay. Frontal neck radiograph. What are your check areas?
So I would look at the cervical spine.
Okay.
So the cervical spine seems to be normal.
Okay.
I would look for any ribs, any cervical ribs in a young patient. I'm not seeing any cervical ribs.
Okay.
I would look for pneumo periphery of the film, so pneumothorax in the apex. Not seeing any pneumothorax.
Anything else?
I would look for the base of skull.
Ignore about the skull.
Okay. The soft tissues,
Okay, look at the
I can see
upper chest cups. Age of the film. Okay.
Not sure.
What's your opinion about this area?
Okay, yeah, there is yeah.
What's your opinion here? What's your opinion here?
So there is mediastinum extending into the.
What's your opinion now?
So there is mediastinum and prevertebral or prevertebral space air lucency, possibly extending from the neck, so resulting in a mediastinum.
So how will you manage?
So this would require urgent ENT referral and thoracic surgical referral. I would also do a CT chest and neck for confirmation, and to look for a source if there's any retro or parapharyngeal abscesses, to exclude them. And yeah, that's
okay. No retropharyngeal abscess. You can see here, no thickening, nothing. Most common cause of pneumomediastinum, as we told, rupture any small belly or rupture esophagus. So if they have to exclude other causes of pneumomediastinum, and the management will be conservative and follow-up. Okay. Just this image is to look at the edge of the film and try to get the finding from limited cuts. Okay. So linear lucences tracking through both tracheal lines extending to the neck, no fracture line, no apical pneumothorax, consistent pneumomediastinum, urgent referral to referring physician, advice full chest radiograph as we did. Patient kept under observation with treatment of primary cause, may need CT if not improved. Okay, thank you, candidate 13, candidate 14. For all candidates, we have quiz at the end of the session. Very interesting cases, by the way. Okay. Candidate 13, 14?
Yes, candidate 14.
Yes, welcome. 3 years old boy brought to our emergency room by his mother 2 hours after he fell on his left outstretched hand.
Okay, this is the X-ray of the elbow, epilateral view. Here I can see the visualization of the interior and posterior fat pad that is suggestive of giant diffusion. Here the radiocapital line is not in contact. The radius is slightly forward, displaced anteriorly, and there's a lucency also noted at the proximal end of the ulna. So in this case, this is suggestive of the fracture at the proximal end of the ulna with the anterior dislocation of the radial radius and with giant diffusion. I will immediately inform these findings to the referring doctor, the orthopedic doctor, for further for further management.
What could be the management for this patient?
This, I think, this needs the surgical management or conservative management.
Reduction.
Reductions.
Okay, because there is radial head dislocation. Well done, you got it, and there is another olecranon tip fracture. Okay, but for this radial head, you have to tell for reduction may need surgical intervention, by the way. Okay, if there is any annular ligament tear or like this. But well done about fusion. Well done about. You have to check always the radiocapitellar line. May someone told there is olecranon tip fracture and ignore about the radial head dislocation. So well done. Urgent referral to pediatric orthopedic team for reduction of radial head and the conservative management for olecranon tip fracture. By the way, this case missed from the orthopedician. Okay. Okay, your second case, 17 years old female patient presented with right-sided chest pain and increasing breathlessness.
Okay, there is a chest frontal projection. Here I can see the lungs are hyperinflated There is reticulonodular shadowing is seen in the lungs bilaterally, which is more pronounced in the central area. There is a moderate pneumothorax is seen on the right side. So these findings are in keeping with the view of the cystic fibrosis. I will immediately inform this finding to the referring doctors. Other differential, because this is a female patient, other differential may include lymphangiomyomatosis. I will inform this finding and will compare the previous radiograph available for further management, especially for the pneumothorax. Immediately intervention should be done. Immediately chest tube should be done, replaced to the management of this pneumothorax.
Okay, you got half marks.
There's
anything else?
There is also small pneumothorax on the left side.
Yes.
There is pneumothorax on the left side is also seen.
If you found big finding, don't stop. Okay? Don't be satisfied. Look for other. Okay? So there is here pneumothorax on the right side, subtle pneumothorax on the left side, ring-like opacity is seen on both lung fields, predominant upper lung zones, likely to be sparing lower lung zones, mostly due to cystic fibrosis. Okay? I think LAM may be differential, but I don't think the case is straightforward. You can write cystic fibrosis.
Okay.
Directly. Okay. Urgent. In short cases, if you found relevant diagnosis, go ahead. Okay. No need for differential. Okay. Because it is not long case.
Okay.
Urgent, inform the referring physician for chest drain. Check patient history, previous imaging. You can advise sweet chloride test and follow up with pulmonology team. Okay. Thank you, candidate 14, candidate 15, last candidate of the day.
Yes, sir. Assalamu alaikum.
Walaikum assalam. Okay. Adolescent male presented with pelvic pain after playing football.
Okay, this is a frontal pelvic radiograph of a adolescent male with pelvic pain after playing football. And the most striking abnormality I can appreciate is that there is an avulsion fracture of the right anterior superior iliac spine. And this is common in this age group. Rest of the visualized pelvic bones appear unremarkable, and bilateral femora and bilateral iliac bones are unremarkable.
Okay.
So this is a case of avulsion fracture, and mostly conservative management in this case. However, I would refer the patient to the orthopedic department, and pain and for analgesia for pain management as well.
Okay. What is the insertion of this anterior superior iliac spine? Which muscle?
I guess sartorius.
Sartorius. Okay. Anterior inferior?
Rectus femoris.
Okay. This greater trochanter?
Greater trochanter, I guess gluteus muscles.
Yes. Yes.
Yes.
Here,
iliopsoas on the lesser trochanter.
Here?
Ischial tuberosity hamstrings.
Okay. So you have to check for any avulsion fracture in adolescent. Okay. So here, iliac crest for abdominal wall muscles. Here, anterior superior sartorius muscle, inferior rectus femoris, symphysis pubis adductor, ischial tuberosity hamstring, lesser trochanter iliopsoas, greater trochanter gluteus. Okay. So avulsion fracture, no other fracture, urgent referral to orthopedic team. May need MRI for assessment of the muscle. Okay. Okay. Neonate with abdominal distension.
Okay. Okay, this is an abdominal radiograph frontal view of a neonate with abdominal distension. I can appreciate that the bowel loops are distended and within the center of the abdomen. And I can also appreciate bowel loops are seen projected over the right inguinal region. And so likely this is a case of bowel obstruction due to a right inguinal hernia. Which is common in this age group, and no air is projected over the liver, and no other abnormality is seen. So concluding my findings, this is a case of bowel obstruction due to right inguinal
What sign
hernia.
of intestinal obstruction?
Sorry?
What's the signs of the intestinal obstruction?
signs of?
Intestinal obstruction, IO, in this
Okay,
case.
intestinal obstruction. There were some prominent bowel loops in the center of the abdomen.
Okay.
Yeah, but not very dilated. However, there is air-filled bowel loops projected over the right linguinal region. So,
Okay, right inguinal hernia, but
yes.
you are not sure about intestinal obstruction. You can simply adjust. I will recommend the cubitus view to see any air fluid level or any sign of intestinal obstruction. If so, I will urgently refer the patient to pediatric surgical team. Okay?
Okay, yes.
You don't have to put a diagnosis from your mind just by expectation.
Okay, yes.
You can, but if there is, I will do like this.
Yeah,
Okay?
there was
Because
not
this,
much distension. Yeah.
yes,
Okay.
this image is not sufficient to judge the intestinal obstruction. So,
Yes.
okay.
Yes, sir.
So, gas-filled bowel loop projected right inguinal hernia, no pneumoperitoneum, no significant bowel dilatation. So, check the decubitus view to exclude air fluid level and pneumoperitoneum. Refer the patient to pediatric surgical team. In this case, we may not need to do urgent, okay? Because no intestinal obstruction.
Signs of, yeah, bowel obstruction. Okay.
Okay, so you can 15, well done. Okay, we'll go for quiz cases. We will follow the chat for the answers, okay? Okay. First case, hand pain after trauma. Any thoughts? Okay. Thorax, left second proximal phalanx. The second is good. Proximal phalanx force fracture, base of force proximal. Yes, the fracture is here. Okay, spacle fracture. Not appears again, subtle, very subtle on the AB view, but on the oblique view, there is a cortical step here, so it is a subtle fracture. Okay, next case. Okay. Any thoughts? Fracture radius. Okay, what else? Torus radius and non extension. Torus fracture radius. Bucket fracture. Fracture ulnar sternal process. Okay. Okay. Here there is buccal fracture of the distal radius. If you saw distal radial fracture, you have to look for the ulna. Also, there is a step here of the distal ulna. So both radius and ulna showing buccal fracture. If you see in the AB view, you will see here and here. If you put only radius, you will take half marks. If you put both, you will get the whole mark. So the base here, if you found buccal fracture of the distal radius, please look at the distal ulna because it is the same mechanism. All an outstretched hand with buckling of the bone. Okay. Next case. Okay, ignore about the proximal phalanx of the third finger. Ignore. Anything else? Okay. If you look here at the distal phalanx of the fourth finger, you will see fracture here. Okay, here in the oblique. I may give you excuse because you couldn't make zooming or like this, but no problem. We are learning. Okay. Knee pain after trauma. Any thoughts? Normal? Okay. At fluid level, we will not judge on the lateral radiograph. Okay, there is deep notch sign here, which is a sign of suggesting of ACL tear. Okay. So we talked today second fracture, arcuate, we didn't show, but we discussed it, and deep notch sign of the lateral femoral condyle, which means may indicate ACL fracture, ACL tear. Okay. Classic exam case. History of chronic disease. Common exam case. Any thoughts? Okay, sickle cell, yes. Sickle cell disease, sclerosis of the humeral head, AVN, H-shaped vertebrae. Okay, mild cardiomegaly, some bone sclerosis, not evident in this case. If you look at the lateral view, you will see the H-shaped vertebrae. Okay, so sickle cell disease, common exam case. You can find here the surgical clips of the cholecystectomy. You can see the splenic flexure here means splenic calcification for autosplenectomy. So it is sickle cell. Okay, next one. Okay. Any thoughts? Eagle eyes. Um, okay. The fracture here is proximal phalanx of the little finger. Okay. This one. And there is lateral dislocation. Where really what's happened in the chat, this will happen in the exam. Everyone told another pathology, and if you saw the pathology, it will be very obvious. So this will happen in the exam. So try to concentrate every bone, see fracture. If the fracture is obvious for you, okay, you have to tell. Okay. Okay. Knee radiograph. No trauma. Edge of the film. Any thoughts? Okay, look here. Intramedullary femoral lesion with calcification in chondroma. This patient confirmed by CT and MRI. Okay. Maybe some blurring of the images. Trauma patient. Distal phalanx of the fifth finger. Yes. 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 Okay. Here is the little finger. Fracture. Well done. Last case of the day. Any thoughts? Okay. Can you see now? Supracondylar, yes. If you see here, there is line here. Okay, it is difficult, but you have to expect. But on the other view, you can see supracondylar function. Okay, thank you all of you.